My first encounter with EMDR happened when I was in graduate school. And I was doing research on a paper. And I happened to pull this book off the shelf that gave a brief description of the incident that spurred Dr. Francine Shapiro to begin developing EMDR. And the description went something like, Dr. Shapiro was walking through a park, and she was thinking about something upsetting. And she noticed that as these thoughts were coming up to her, her eyes were moving back and forth. And then when she went back to those thoughts, they were less disturbing to her. And I have this very clear picture in my mind of standing there in the library amongst the stacks of books and reading that and going, oh my God, that's such a load of garbage, and slamming the book shut and putting it back on the shelf and walking away and never giving it a second thought. And that perception probably never would have changed if not for a friend and a colleague. Her name was Angie. And she and I worked together briefly at NRTC together. And I'd been a licensed counselor for about 6 years at this time, and I was working at this job that I wasn't very happy with and trying to figure out what I wanted to do with myself next, when out of the blue I get this call from Angie. And Angie's husband was active duty military, and she tells me, our next duty station is Germany. We're going to be leaving in a few months, and my boss asked me to help her recruit somebody to take my place. Would you be interested in my job? And she told me what she was doing, and I said, yes, I would definitely be interested. And so as I transitioned into this new job, Angie was there, and she was showing me the ins and outs and transferring her caseload over to me. And we talked about a lot of things. And one of the things we talked about was EMDR. And she had taken the training about a year ago, and she said, I found this to be something that's really beneficial for my clients. If you ever have the chance, I would really recommend that you take the training. And because I knew Angie and I knew her work as a clinician and I respected that work, her opinion on EMDR held weight for me. And so a couple months down the road, I happened to come home from work, and there's this flyer in the mail for an EMDR training. So I decide I'm gonna go to the training. And I'm at the training, and I'm really kind of intrigued by the ideas that were presented. This was all new information for me, kind of information about the brain, the neurobiology of information processing, and how trauma affects that process, and how trauma affects the brain. So I'm sitting there, and I'm starting to get the sense that, okay, this could be something that would really help the client population I was working with at the time. But I go back to my practice, and I struggle. And I struggle with how to implement EMDR into what I was already doing therapeutically with my clients. And then one day I had this experience with this woman I was working with. And she came to see me because she had lost her husband about a year ago. And initially she had done well. And then the first anniversary of his death rolled around, and she really began to struggle. She was having significant symptoms of depression. Her anxiety was really high, so much so that she had taken a leave of absence from work. And so I'm wondering, how am I going to help this woman? And one of the things she kept struggling with was her husband. They were both fairly young. They were both in their early 50s, and he had been diagnosed with kidney cancer, and that led to his death. And what she struggled with was his suffering, and she kept flashing on this image of what he looked like just prior to his death. And as we're talking about this, I start thinking about EMDR, and I'm wondering, is this something that would be helpful for her? And so I tell her, I've been trained in this new therapy. I'm wondering if you would be willing to give it a go and give her some information about what EMDR is. And she says, if it will help me, I'm willing to try anything. So we spend the remainder of the session doing EMDR, and what we work on is this image of her husband. And me being the novice EMDR clinician, I think it goes well, but I'm not real sure. And so I'm curious about, okay, what did this do for her? Is this going to help her at all? And so when she comes back in to see me the next week, I ask her, what did you notice after you left here? And she looks at me and she goes, it's really weird. But when I think of my husband now, what comes up for me is not that image, but how he looked like before he was diagnosed with the cancer, when he was young and healthy. She said, if I want to see that other image, I have to actually go and look at a photograph. And so behind my professional demeanor, there's this completely different conversation going on in my head. And that conversation is like, oh my God, the picture went away. How did that happen? And I can't do that with any other form of therapy that I know. And so that's when I made the decision that this is what I was going to focus my professional time and effort on. And so I really devoted myself to learning how to do this therapy model and how to do it well. And so that was about 9 years ago. And I use EMDR in my practice on a daily basis. I work mostly with adults who have complex trauma, and I feel like, I couldn't do that work without EMDR. So that's a little bit about how I came to be here. So let me start talking about EMDR specifically. And the story I related about the walk in the park, that is a true story. That is how EMDR started. It was a chance discovery. And Dr. Shapiro was taking a walk. She was thinking about something upsetting. And she noticed, and just paying attention to what she was experiencing. And she noticed that as she went back to those disturbing thoughts, the emotional charge connected to them had gone away. And so she started paying more attention to what was happening. And she noticed that when the thoughts came up, her eyes would start to move back and forth. And so she was intrigued by this. And she started having people come to her office, think of an upsetting memory, and move their eyes back and forth. And one of the first things she noticed was that people had a hard time moving their eyes back and forth. But if she guided the eye movements, they had an easier time with it. And over time, she began to craft a system. And that system consisted of things like how to help people access a memory, how fast to do the eye movements, how long to do the eye movements for. She added in a negative cognition connected to the upsetting memory and a desired positive cognition. And she also started tracking level of disturbance. So her initial pilot study was done in 1987. And that pilot study compared the eye movements with a modified flooding technique. And what they found in this study was that the folks with the modified flooding technique, they sat with an upsetting memory along with a therapist. And for those folks, they noticed that their level of distress immediately went up, which is what happens with exposure techniques. The stress response initially goes up and then tapers off over time. With the eye movement group, they noticed the level of distress immediately went down, but there was also an increase in the desired positive cognition. And so what Dr. Shapiro walked away from this study with was the idea that, well, this is interesting, and it deserves to be looked at more closely. And she encouraged other people to do research on this as well. And what she initially thought she had discovered was just a desensitization technique, a way to desensitize the disturbance connected to memory. And she initially called it EMD, eye movement desensitization. And the next thing she did was she also began training people on how to use this technique. And these folks that she trained became her early collaborators. And so they would go off to their practices, use EMD, and come back and talk to her about what they had discovered. And so what they kept coming back to was they kept underlining that there was this positive shift in self-perception. People had a deeper insight, and there was positive change in related incidents. And so what she came to realize what was happening was not just simple desensitization, but fully reprocessing a memory. And she moved away from seeing this as just a technique, but as a fuller treatment model. And she changed the name to EMDR, eye movement desensitization and reprocessing. And she also incorporated the idea of information processing. So I'm not going to spend a whole lot of time on research, but I just wanted to touch on a couple. So the Ironson study had compared two treatments for traumatic stress, EMDR and prolonged exposure. And the results found that 70% of EMDR participants achieved a good outcome in 3 active treatment sessions, compared to 29% of the prolonged exposure participants. and EMDR also had fewer dropouts. The Jabbergandi study, comparison of CBT and EMDR for sexually abused girls. Both EMDR and CBT produce significant reduction in PTSD and behavior problems, but EMDR was significantly more efficient, using half the number of sessions to achieve the results. And with EMDR, we don't require any type of homework. The Marcus study was a study of PTSD using EMDR in an HMO setting. And the results showed that 100% of single trauma and 80% of multiple trauma survivors were no longer diagnosed with PTSD after 6 50-minute sessions. And the Wilson study, this was funded by, it's the Marcus study that was funded by Kaiser Permanente. So in the Wilson study, 3 sessions of EMDR produced clinically significant change in traumatized civilians on multiple measures. And in follow-up, 84% no longer met the criteria for a diagnosis of PTSD. So that's just been some of the research that's been done. More research has been done in the treatment of trauma using EMDR than all other therapy models combined. And EMDR has been recognized as an evidence-based, top-tier treatment by numerous organizations. So, some of the myths connected with EMDR. One is that EMDR is accomplished in a few sessions. And that's only true if there has been a single incident trauma. You know, if I have somebody come into my office and their history is relatively clear, there's just this one incident that's been overwhelming for them or traumatic, those folks, you know, I might just see for a handful of sessions. But if there's complex trauma or multiple traumas, treatment generally takes longer. The history of the client's very important. We need to have an understanding of their history in order to create an effective treatment plan. We just needing to know the basics of EMDR, and with EMDR, anyone can treat complex trauma. You know, treating trauma is complex, and so there's a lot to know about trauma and a lot to understand about EMDR in order to treat trauma. And EMDR is not just used to treat trauma, it has lots of other applications, and we're going to touch on that in just a minute. And EMDR is not a technique. EMDR is a distinct, comprehensive treatment approach. It's built on good clinical skills, including assessment, diagnosis, treatment planning, and EMDR is never a replacement for those essentials of good clinical practice. So some of the other applications of EMDR, we have, of course, PTSD and complex PTSD. Depression, you know, there's a lot of depression that has underneath it loss. There's loss through death, through divorce, failures, all of which can be addressed with EMDR. Dissociative disorders, you know, EMDR is not the first line of treatment for dissociative disorders. It's generally stabilization. But when it comes time to process the underlying trauma, EMDR is the treatment method of choice. Children, EMDR is widely used with children. Phobias, complicated grief, addictions. One of the ways we use EMDR with addiction is, you know, sometimes trauma is the underlying root of the addiction. And then with addiction, there's all kinds of debris as a result of the addiction. There's loss of relationships, loss of family, loss of jobs, loss of finances, all of which can be addressed with EMDR. There are also 2 EMDR protocols that can be used to specifically address the addictive behavior. Anxiety disorders, and there's a whole body of work on performance enhancement and peak performance. So I want to take a little bit of time and discuss how we, yes ma'am. What age do we use with children? The folks I know that use EMDR with children, it's usually age 3 or 4. I have read case studies where they've used it with children as young as 18 months and 2 years old. So, and with children, we have to do it differently. We have to modify the protocol, to meet their, so that they can understand it. So a lot of clinicians who do EMDR with children incorporate play therapy and art therapy in it too, and sand tray and things of that nature. So you're welcome. Okay, so we're talking about, when we talk about EMDR, we talk about trauma. And so we're in the process of changing our language about trauma. And when we think about trauma, almost what automatically comes to mind are those large, life-threatening events where the emotional response is just massive. But we're starting to discover that there are other aspects of trauma. And in EMDR, we talk about big T trauma and repeated disturbing life experiences. And so big T trauma are those life-threatening experiences that generally come to mind. Things like combat, being the victim of a crime, all types of assaults, natural disasters, childhood abuse. Repeated disturbing life experiences are smaller events that by themselves may not be that impactful, but if they happen repeatedly or happen under certain circumstances, they accumulate over time and build up in our nervous system. So some examples of that may be, as a child being shamed by a parent, and so, dad may not have to say anything, but he just has that look that tells you, you're bad and you're in trouble. And again, if that just happens once or twice, it's probably no big deal. But if it happens from early childhood throughout adolescence, the impact is much larger. Other examples might be, as a child, hearing your parents fight night after night, working for a demanding, demeaning boss year after year. And as therapists, compassion fatigue is another form of the buildup of disturbing life experiences. Every day we have people come into our office and we witness their pain. We see it on their face, we hear it in their voice. Sometimes we hear just awful stories, and that accumulates, it builds up. There was a study done in England in 2008 that looked at these two types of trauma. And they had a large group of people diagnosed with PTSD, and they also had access to extensive historical records on these folks. And what they did was they kind of culled through the information and they looked for causative factors. And they separated these folks into two groups. One whose PTSD was the result of big T trauma, and the other group whose PTSD was the result of this accumulation of disturbing life experiences. And then they took the study a step further and they looked at severity of symptoms. So would anybody care to venture a guess of which group had the more severe symptoms? No? I'm sorry?
The chronic, ongoing.
Yes, the people whose PTSD resulted from this buildup of experiences had slightly more severe symptoms. And that study may validate what you guys already know from your own practice and just seeing that in the folks that you work with. So the next thing we're going to talk about is memory and information processing. And so from all the research that we have to date on trauma, the most compelling information doesn't come from psychology, but from neurobiology, and specifically the neurobiology of information processing and memory formation. And it's the neuroscientists who provide the most helpful data to further our understanding of the origins of trauma, the mechanisms of the impact of trauma on the brain and the body, and what can be done about it.